Okay, let's dive right in. You know that feeling, that little tickle that turns into a full-blown scratchy throat, or your nose just decides, nope, locked solid, maybe that dull ache in your ear that just ramps up.
Mm-hmm.
These aren't just little annoyances, are they? They're super common, they really disrupt things, and honestly, trying to figure out what's what and what to actually do about it, it can feel kind of overwhelming.
Absolutely. And, that complexity is exactly why we're digging into this today.
Yeah.
Because collectively, these kinds of things, they're the #1 symptomatic reason people in the U.S. go see a doctor.
#1, wow.
Yeah, we're talking millions and millions of visits every single year. It's huge.
It really is. And so this deep dive, it's specifically for you, the listener. You've given us this source material, Chapter 35, which takes a really comprehensive look. And our mission today is to unpack it together. We want to get beyond just, my throat hurts and really explore the whole landscape, the causes, how things develop, how diagnoses are made, what treatments actually work, and just as important, what treatments don't.
Think of us as guides through this detailed map, this chapter. We're aiming to pull out the key knowledge, the insights, basically getting you to that level of understanding where you feel really well informed. Like you can navigate this stuff with the insight of someone who's, really dug into the core material.
Right. We'll be hitting everything from the good old common cold and those awful ear infections to sinus issues, sore throats, looking at the causes, the symptoms, how doctors figure it out, the treatments. And there are some surprising things in here, some really important distinctions the material makes.
It's going to be a conversation, pulling out the nuggets that matter from this source. So yeah, let's get comfortable and start this deep dive.
Okay, so where do we start? Foundation first.
Let's do that. Let's establish the basics. We're focusing on what the material calls upper respiratory infections, or URIs. And the key definition here is that these are acute infections happening in the respiratory tract above the vocal cords.
Above the vocal cords. Okay, that's the dividing line. So it separates them from things happening lower down, like bronchitis or pneumonia.
Exactly. Those are below the vocal cords. This material specifically flags several URI examples.
Mm-hmm.
The non-specific URI, which basically your common cold, then otitis media, that's ear infections, sinusitis, which affects the sinuses, and pharyngitis, essentially a sore throat. And the sheer number of people hit by these every year, well, it shows why understanding them is so important.
Yeah, the numbers are pretty staggering. It says the average adult gets, 2 to 4 URIs a year?
Yeah.
And kids? Oh boy, kids average 6 to 10.
6 to 10. It really hammers home the impact, doesn't it? All that time feeling unwell, missed school, missed work.
Definitely.
The material also points out, and this is important, that there's often overlap with those lower respiratory tract infections like flu, bronchitis, pneumonia, and even just a non-infectious cough. Symptoms don't always fit neatly into one box, especially at the start.
Right. And it mentions prevention, too, things we've all become very familiar with recently. Hand washing, using sanitizer, keeping distance, masks, isolating when sick, cleaning surfaces.
Yeah, all the basics, which actually leads right into the connection with COVID-19 that the material really emphasizes. SARS-CoV-2, the virus behind COVID-19, it can show up with symptoms that mimic pretty much any URI.
Right, like fever, chills, cough, feeling breathless, fatigue, muscle aches, headache, runny nose, sore throat, even nausea, vomiting, diarrhea.
And the really distinctive one, the new loss of taste or smell, that was a big clue early on, wasn't it?
For sure.
Symptoms could pop up anywhere from 2 to 14 days after you were exposed. But here's a really critical point the source makes. In places where SARS-CoV-2 is circulating, any respiratory symptom, literally anything, should be treated as potentially COVID-19 until, widespread immunity changes the picture. That completely shifted how doctors had to approach these common symptoms.
That context is absolutely vital. Okay, so now let's shift gears to something the material puts a lot of weight on, improving how antibiotics are prescribed outside of hospitals. Antibiotic stewardship, right? This feels like a major theme.
Oh, it absolutely is. It's central. The basic problem, and the material states this very strongly, is that the vast majority of these acute respiratory infections, they're caused by viruses.
Right.
They're self-limited. Your body's immune system will clear them up eventually on its own schedule.
And antibiotics.
Yeah.
Well, they only work against bacteria. So for these viral things, the material says they don't speed up recovery and they don't prevent complications in most cases.
Exactly. But despite that, here's the really alarming statistic presented. At least half, 50% or more, of all antibiotic prescriptions given out in clinics or doctors' offices for acute respiratory infections in the U.S. are considered inappropriate.
Half. That's huge, especially when you look at the international comparison I mentioned. Prescribing rates vary almost threefold across countries, but there's no difference in how often serious complications happen. It really suggests some places are just prescribing way, way too much.
It definitely raises questions about why that's happening. And the material lists several potential reasons clinicians might prescribe when they maybe shouldn't. Things like time pressure during appointments.
Always a factor.
Yeah. And the understandable fear, of missing that one rare case that actually is bacterial, or worrying about preventing some super rare complication, even if the actual risk is tiny. Sometimes maybe not fully appreciating the potential downsides of the antibiotics themselves. And then there's the mistaken belief that patients expect or demand antibiotics, that they won't be happy without a script.
Those are real pressures in a busy clinic. But the consequences of using antibiotics inappropriately, as the material details, they're pretty substantial, aren't they, for the patient and for public health?
They really are. For the individual patient, you've got the risk of side effects. Could be a simple rash or diarrhea. Could be something more serious. It messes with your gut microbiome, which we know has all sorts of health implications down the line. And it significantly bumps up the risk of getting a C. diff infection, which can be really nasty.
Right.
And then zooming out, it drives up healthcare costs. And this is the big one. It fuels the rise of antibiotic-resistant bacteria, which is, a massive global threat.
So antibiotic stewardship, which used to focus mainly on hospitals, really needs to shine a light on clinics and outpatient settings now.
Absolutely, because that's where the bulk of antibiotics are used. Something like 85% in developed countries happens outside hospitals. That's where you can make the biggest dent. The CDC's core elements of outpatient antibiotic stewardship from 2016 are highlighted as the roadmap here.
And those core elements, let's see, committing to doing better, putting policies in place and checking if they work, tracking prescribing habits and giving feedback and educating both the clinicians and the patients. It sounds like it needs a multi-pronged attack.
It does. And the material lists interventions that seem to work. Things like peer comparison, showing doctors how their prescribing stacks up against others.
That can be powerful.
It can be. Also, making doctors justify why they're prescribing, using clinical decision support tools built into electronic records, and really good patient education. It seems like combining several of these strategies is usually the most effective approach.
I noticed it specifically called out communication training as being really impactful, like learning how to clearly explain the diagnosis, focus on positive things the patient can do rest, fluids, setting realistic expectations about how long it might last, often 5 to 14 days, right? Not just a couple.
Yes, that's crucial. And also clearly explaining the red flags, the symptoms that would mean they need to come back. That whole communication piece is vital for keeping patients happy and managing expectations without just handing out antibiotics.
Makes sense.
The material also gives a nod to telemedicine, suggesting it might actually help reduce inappropriate prescribing, maybe because it allows for more standardized approaches or there's less perceived pressure from the patient.
What about those lab tests people hoped might help tell viral from bacterial, like procalcitonin?
Yeah, the material is pretty clear on that. Tests like procalcitonin or C-reactive protein, while they've been looked at, they haven't really panned out as being reliably helpful in the outpatient setting for guiding antibiotic decisions for these respiratory infections. They're either not effective or the effect doesn't last.
Okay. And here's something that might surprise some people. The material explicitly says that giving a delayed antibiotic prescription, the one you tell a patient to fill only if they don't get better, it says that's conceptually flawed and should actually be avoided.
Yes, that's a strong stance they take. The reasoning laid out is pretty clear. These delayed scripts are usually given for viral infections anyway, things that are expected to get better on their own, things where antibiotics aren't appropriate in the first place.
So it kind of ignores the natural history of the illness, which can drag on for a while anyway.
Exactly. And it puts the burden of deciding whether to take the drug onto the patient. You're basically asking them to make the clinical call.
Which also sends a really confusing message, doesn't it? Like, well, maybe you need it, maybe you don't. It muddies the water about whether it's truly necessary.
Right. It completely undermines that goal of clear communication and reducing unnecessary use. So, yeah, to wrap up this foundational part, URIs are super common, overwhelmingly viral, and antibiotic overuse is a big problem with real harms. Good stewardship hinges on accurate diagnosis, great patient communication, targeted clinical strategies, and steering clear of practices like delayed prescriptions that don't really help.
Okay, that's a really crucial backdrop. With that firmly in mind, let's start digging into the specific conditions the material covers. First up, the non-specific upper respiratory infection, aka the common cold.
Ah, yes, the undisputed champion of making us feel miserable for a week or so.
Hmm.
The material defines it pretty simply. It's a URI where no single symptom really dominates the picture.
And the main cause, like we said, is viruses, spreading through contact, surfaces, droplets, all the usual suspects.
And the list of viruses that can cause it's kind of mind-boggling, which explains why we keep getting colds. You've got rhinoviruses, over 100 types of just those. Then there are the common coronaviruses, not COVID, parainfluenza, RSV, influenza itself, adenoviruses, 57 types of those, metapneumovirus, bocavirus.
It's like a never-ending lineup.
It really is.
Yeah.
And the material makes the practical point that trying to figure out the exact virus causing your cold usually isn't practical or cost-effective or even necessary for managing it. You can do fancy PCR tests, but they might just pick up bits of virus from an old infection, giving you a false positive.
Right. Which leads to the point about differential diagnosis. When someone comes in with cold symptoms, the doctor needs to think, could it be something else, like the flu or measles maybe, especially if there's that trio of cough, runny nose, and conjunctivitis.
Or even acute HIV, where sore throat or a rash might be more prominent. And of course, COVID-19 is always on that list now.
Our individual susceptibility plays a role too, right? The material mentions things like previous exposures. The immunity to many cold viruses is often specific to that one type or doesn't last long.
Meaning you can get infected again pretty easily.
Yeah. And then general health, genetics, even our gut microbiome, stress levels, they all seem to factor in.
So the symptoms, they usually creep up gradually after you've been exposed, maybe 2 to 8 days later. The classic picture is that nasal fullness or stuffiness, runny nose, maybe a sore throat, perhaps some hoarseness from laryngitis, swollen glands in the neck, a cough, and often a low-grade fever.
It notes that muscle aches can happen, but they're usually not as bad as with the flu. And nosebleeds are common too, especially if you're blowing your nose a lot.
Looking at the physical exam findings, they can vary a lot. You might see red eyes, a red throat, maybe those white spots or streaks called exudates, or that bumpy cobblestone look at the back of the throat. Inside the nose, the lining might look pale and swollen or red. Mucus can be watery or thick and colored. Lungs usually sound clear, though sometimes you might hear some wheezing, which can still be just from the virus.
And the duration, this is a really key piece for managing expectations. Symptoms often peak early, but the material says they usually last 5 to 10 days and often stretch out to 14 days, 2 full weeks.
That's way longer than many people think a cold should last, which brings us to treatment. For adults and older kids, the focus is squarely on relieving symptoms.
Right. Treating the misery, not the virus itself. So for fever, aches, sore throat, acetaminophen, or NSAIDs like ibuprofen, runny nose, the material lists ipratropium bromide nasal spray as an option. Congestion. You've got the nasal decongestant sprays like oxymetazoline, but crucially use them for no more than 5 days, or you risk rebound congestion.
Or the oral decongestants like pseudoephedrine. Combination products are out there too, mixing decongestants with pain relief or antihistamines. For cough, things like dextromethorphan or benzonatate get mentioned, but with a big caveat. The data supporting how well they actually work is pretty weak.
And opioids for cough. Effective, maybe, but the material flags the significant downsides. Drowsiness, feeling weird, constipation, and addiction potential.
And here's a really strong warning, a clear guideline. For kids under 6 years old, cough and cold medicines should not be used, period. Too risky, not enough benefit.
That is so important for parents to hear. So what can you do for little kids? The material suggests honey for sore throats, but only if they're over 1 year old because of the botulism risk. Cool mist humidifiers can help breathing. And saline drops in the nose, followed by gentle suctioning, can help clear congestion.
General advice for anyone with a cold is also key. Know that symptoms peak early but can hang around for up to 2 weeks. You're generally contagious as long as you have symptoms. And the classics: rest and drink plenty of fluids.
And the material clearly lists those red flags reasons to go back to the doctor, like a fever over 102 degrees air, chest pain, unless it's obviously muscle strain from coughing, shortness of breath, feeling dizzy or confused, developing new pain in your ear or sinuses, or if symptoms just aren't getting better after 14 days.
And hammering home that antibiotic point again, while yes, complications like bacterial ear or sinus infections can happen after a cold, for any one person with a cold, Giving them an antibiotic is actually more likely to cause a side effect than it is to prevent one of those complications. That framing really shifts the perspective, doesn't it?
It absolutely does. It makes you think twice about asking for antibiotics just in case. And speaking of things to maybe avoid, the material lists a whole bunch of remedies that it considers ineffective, questionable, or potentially risky for colds.
It's quite a list. Echinacea, zinc, inhaled steam, vitamin C, vitamin D, garlic, antihistamines often don't help much for colds, various Chinese medicinal herbs, steroid nasal sprays for just cold symptoms, that pelargonium herbal extract, saline nasal irrigation, listed here as questionable for colds, which is interesting, and specific antiviral drugs aimed at cold viruses. It shows just how many common remedies don't have strong evidence behind them.
Okay, let's move on from the nose and throat to the ears. Ear pain. Another really common complaint, often tagging along with or following these URIs.
And the material points to two main culprits originating in the ear itself: otitis externa and otitis media.
With a useful clue for adults, if the ear pain is coming from the ear itself, it almost always comes with some change in hearing.
Well, what's really eye-opening here is the huge list of other things that can cause pain felt in the ear.
Yeah.
The nerve supply is so complex that pain can be referred from lots of different places.
Like for folks over 50, it mentions thinking about temporal arteritis, especially if there's headache, feeling unwell, weight loss, fever. And importantly, the ear exam itself looks totally normal.
Right. Or in people who smoke or drink heavily, you have to consider head and neck cancers. In kids, always think about a foreign object stuck in there.
And then there's all that referred pain, cranial nerves V7IXX, plus neck nerves C2 and C3 all supply the ear area. So problems anywhere along those pathways can show up as ear pain.
Yeah, things like trigeminal neuralgia, viral stuff like Ramsay-Hunt syndrome, that's shingles affecting the facial nerve, causing blisters near the ear, facial paralysis, hearing issues.
Dental problems are a huge one, right? Cavities, abscesses, grinding your teeth, bad bite, TMJ disorders. They all commonly refer pain to the ear. Salivary gland issues, swollen neck glands too.
Other infections nearby sinusitis, tonsillitis, pharyngitis can radiate pain via cranial nerve NIX. Even GERD, acid reflux, is often linked to ear symptoms, including pain.
And the really surprising one the material mentions, a heart attack can rarely cause referred ear pain through the vagus nerve, CNX.
It just shows you have to think broadly. There's also a rare inflammatory condition mentioned: relapsing polychondritis recurrent, painful red swelling of the outer ear cartilage, but it specifically spares the earlobe. That can affect other cartilage too.
Okay, let's narrow back down to the two most common ear-specific causes, starting with otitis externa, better known as swimmer's ear.
Right. This is inflammation or infection of the external auditory canal, the tube from the outside to the eardrum. You get pain, redness, swelling, maybe some discharge, and hearing can be affected.
Usually caused by bacteria, especially Pseudomonas or Staph aureus. Fungi like Aspergillus or Candida can cause it too.
It's most common in older kids and teenagers. Risk factors are pretty clear. Water exposure, especially swimming, hence the name, more common in summer. Also, poking around in there with cotton swabs or hearing aids, having naturally narrow canals, earwax blockage, or skin conditions like eczema. That classic swimmer's ear is usually bacterial.
And the key finding on exam is pain when you wiggle the outer ear or press on that little flap in front, the tragus. The canal looks red, swollen, maybe gunky. Fungal infections, interestingly, often cause more itching and discharge than severe pain.
You might feel swollen lymph nodes nearby, too. And it's important to tell it apart from a middle ear infection, AOM, where the eardrum has burst. Both might have discharge. But with the ruptured eardrum, moving the outer ear shouldn't hurt, like it does with otitis externa.
The material also flags malignant otitis externa. That sounds much worse.
It is. It's a severe, potentially life-threatening infection that spreads into the temporal bone, usually seen in people with diabetes or other immune problems, often older adults. They might have a fever, and it can even affect cranial nerves.
Okay, so how do you treat regular otitis externa? Starts with pain relief, right? Acetaminophen or NSAIDs.
Yeah. And the mainstay, according to the material, is topical ear drops, usually combining an antibacterial drug with a steroid, used for 7 to 10 days. A common one is polymyxin B-neomycin hydrocortisone. But there's a big warning. Don't use that if the eardrum might be perforated, because the neomycin can damage the inner ear.
Ah, good to know. So what's safer if there might be a hole?
Ciprofloxacin hydrocortisone drops are a good alternative then. Another option listed as effective is topical aluminum acetate might work just as well as the antibiotic steroid drops. If things are getting better in a few days, sometimes they put in little wicks or gauze soaked in the medicine to make sure it gets down the whole canal.
And what doesn't work for typical swimmers here?
Oral antibiotics are listed as ineffective, and surprisingly, topical antifungals is the main treatment, even though fungi can cause it. For prevention, especially after swimming, using drops with acetic acid or aluminum acetate periodically can help.
And that malignant otitis externa needs much more firepower. Oral antibiotics, targeting Pseudomonas, maybe IV meds for pain, fluids, serious stuff.
Okay, let's flip to the other major ear pain cause, acute otitis media, or AOM. This is overwhelmingly a childhood illness.
Yeah, the stats are wild. Peaks between 6 and 24 months. Something like 60% of kids have had it by age 6.
That's right. And the reason younger kids are so prone is partly anatomy, partly immunity. Their eustachian tubes connecting the middle ear to the back of the throat are shorter, more horizontal, and just don't drain as well as in adults. Plus, their immune systems are still learning the ropes.
And the process usually starts with a viral URI, doesn't it? Causes swelling, blocks the eustachian tube, fluid builds up behind the eardrum.
Exactly. And then bacteria that are normally just hanging out in the back of the nose and throat see this nice pool of stagnant fluid and decide to set up shop. Boom, bacterial infection, AOM.
So it's often a viral cold that then gets complicated by bacteria moving into the ear. The material lists the usual viral suspects, RSV, rhinoviruses, flu, etc., and the common bacteria causing the ear infection itself. Strep pneumo, non-typable H. flu, Marcella, and strep pyogenes.
That sequence virus sets the stage. Bacteria takes advantage is really key. So what does AOM look like in kids?
Well, little ones can't say my ear hurts, so you might see irritability, maybe tugging at the ear, though that's not super specific. Sometimes discharge if the eardrum bursts, poor feeding. But the real diagnosis comes from looking in the ear with an otoscope.
Right. The material describes what to look for. A bulging eardrum, it looks inflamed, cloudy. You can't see the landmarks behind it clearly. And critically, it doesn't move properly when you gently puff air in, that's pneumotoscopy, or when the child tries to pop their ears. Plus, there's usually some conductive hearing loss because the fluid blocks sound.
It also lists signs of a severe case. Moderate to severe ear pain, pain lasting 48 hours or more, or a fever over 102.2 degrees from chart, 39 degrees C.
And based on these signs, there are clear diagnostic criteria outlined for kids. It's definitely AOM if there's moderate to severe bulging of the eardrum or if there's new ear discharge that isn't from swimmer's ear.
If the bulging is only mild, then it's AOM if symptoms started less than 48 hours ago or if the eardrum looks intensely red.
And the flip side, you should not diagnose AOM if there's no sign of fluid behind the eardrum. That effusion is essential for the diagnosis.
Okay, diagnosis made. Now, treatment in kids. Pain management comes first. Right?
Yeah, absolutely. Pain relief is paramount. NSAIDs like ibuprofen or acetaminophen work well for mild to moderate pain. Those numbing eardrops with things like benzocaine, they might give a little extra brief relief, but they don't replace the oral pain meds.
And here's where the antibiotic stewardship message really hits home for AOM. The material says up to 80% of kids' AOM gets better without any antibiotics.
That's a massive number, and it drives the treatment approach. The material lays out specific situations where antibiotics are generally recommended, often based on guidelines. It references a table. Basically, antibiotics are reasonable for all babies under 6 months. For kids 6 months to 2 years, you treat it if both ears are involved or if there's ear discharge otorrhea. For kids over 2, you usually treat only if symptoms are getting worse or haven't improved after 48 to 72 hours of just watching and managing pain. But for any age, if they have those definite AOM signs plus severe pain, pain for 2+ days, or that high fever, over 102.2 degrees Fist, then antibiotics are indicated.
So specific triggers for antibiotics, but often watchful waiting is the way to go, especially for older kids with milder symptoms. And the material really weighs the benefits versus harms of antibiotics here.
It does. It says the benefits are modest. Antibiotics don't make the pain go away super early, but they might reduce pain by day 2 or 3. But the number needed to treat, NNT for that, it's about 20. You have to treat 20 kids with antibiotics for just one extra kid to feel better by day 2, 3 compared to not getting antibiotics.
Wow, treat 20 for one to feel better a bit sooner. What about the downsides, the harms?
They're more common. More kids on antibiotics get side effects like vomiting, diarrhea, or a rash. The number needed to harm, NNH, is about 14. Treat only 14 kids, and one extra kid will get one of those side effects.
NNT of 20 for a modest early benefit versus NNH of 14 for common side effects. That really paints a picture of why routine antibiotics for AOM aren't always the best idea.
Exactly. And then there's the question of preventing serious complications like mastoiditis. It's rare, but serious. The NNT to prevent just one case of mastoiditis, it's estimated at around 5,000.
Treat 5,000 kids with AOM to prevent one case of mastoiditis. That's staggering.
It strongly supports the recommendations like the one from the American Academy of Family Physicians highlighted in the material. Don't routinely prescribe antibiotics for kids aged 2 to 12 with non-severe AOM if observation is reasonable.
Okay, but when antibiotics are needed, what's the go-to?
High-dose amoxicillin is the first choice, 90 millikilog a day, max 3-day. Alternatives include some cephalosporins like ceftonir, cefuroxime, cepodoxime, or an injection of ceftriaxone. If the child had amoxicillin recently, the last 30 days, then amoxicillin clavulanate is preferred.
And how long is the treatment course?
It varies. 10 days for kids under 2 or those with severe symptoms, 5 to 7 days for kids 2 to 5 with mild-moderate AOM, and just 5 days for kids 6 and older with mild-moderate symptoms. If they're not getting better after 2-3 days on the first antibiotic, the material says switch to amoxicillin clavulanate, a different cephalosporin, or that ceftriaxone shot. Still no improvement after that second try. Time to refer to an ENT specialist.
It mentions that fluid behind the eardrum, that effusion, is really common after AOM like 60–70% of the time, and it should clear up on its own over about 3 months.
Right. And ear tubes, tympanostomy tubes, might be considered if a child gets AOM repeatedly, like 3 times in 6 months or 4 times in a year. And if you see signs suggesting mastoiditis, that swelling or tenderness behind the ear that needs immediate attention.
What about AOM in adults? It's rare, right?
Much rarer. And there's less solid evidence on treatment. But generally, the recommendation is to treat adult AOM with antibiotics, regardless of whether it's one ear or both, or if there's discharge. Amoxicillin is still the choice, plus decongestants and pain relievers. If an adult gets more than 2 episodes a year or has persistent fluid, they should see an ENT.
Okay, let's quickly cover otitis media with effusion, OME, sometimes called serous otitis media. This is different. It's fluid behind the eardrum, but without an active infection.
Right. Again, mostly kids, especially under age 2, and often recurrent.
It frequently follows a viral cold or an episode of AOM, but allergies can cause it too. Factors like allergies, certain facial structures, reflux, enlarged adenoids can make it more likely.
The main issue with OME is the hearing loss it causes, because the fluid dampens sound transmission. In kids, if that lasts a long time, it can potentially affect speech and language development. Less commonly, kids might feel ear fullness, maybe some mild pain, ringing, or balance issues.
On exam, the eardrum might look dull, gray. Maybe you see fluid levels or bubbles. The light reflex is gone, and the drum doesn't move well.
Evaluation might include hearing tests. Usually, ONE clears up on its own within 4 to 6 weeks. If it sticks around for more than 3 months, it's called chronic OME.
The material mentions a rare complication called cholesteatoma, basically skin cells growing where they shouldn't behind the eardrum, which can cause damage.
Treatment for OME, especially if it's persistent and affecting hearing or development, it's mainly surgical, making a tiny hole in the eardrum, myringotomy, and putting in ear tubes.
Maybe removing the adenoids if they seem to be contributing.
But importantly, the material stresses that medications like antihistamine, steroids, or antibiotics do not reliably help clear up OME.
There it is again. Antibiotics aren't the answer for everything ear-related. Kids at risk for speech delays might need tubes sooner to fix the hearing loss.
Now, let's quickly touch on a more serious condition, acute mastoiditis.
Right. The material calls this a serious infection, significant morbidity, most common in kids under 2, but can happen at any age.
Often follows AOM, but not always. In older kids, you might suspect an underlying cholesteatoma. Basically, the infection spreads from the middle ear into the mastoid bone's air cells behind the ear. It can just be fluid, incipient, or actually destroy the bone, coalescent.
Which often leads to an abscess forming under the skin bone covering, causing that classic swelling behind the ear. The bacteria involved are similar to AOM strep pneumo, strep pyogenes, H. flu, Staph aureus, including MRSA, Pseudomonas.
Symptoms might be worsening ear pain, fever, lethargy in a child being treated for AOM. If that abscess forms, you see the redness, tenderness, swelling, and the earlobe getting pushed forward and out. Inside the ear, you usually see AOM signs. Maybe the back wall of the canal looks pushed forward.
And the potential complications are scary. Facial nerve problems, inner ear infection, skull bone infection, brain abscess, meningitis, blood clots in brain veins, abscesses spreading down the neck. Serious stuff.
Evaluation involves blood tests showing inflammation. Imaging isn't always needed for a classic case in kids, but definitely if you suspect complications. CT is the go-to, showing the bone destruction, fluid abscesses. MRI is better for soft tissues and blood vessels.
Differential diagnosis includes skin infections, severe swimmer's ear, swollen nodes, cartilage infection, even tumors.
Treatment. Hospital admission is standard.
Makes sense.
Mainstays are CV antibiotics and draining the middle ear via myringotomy, often with tubes. If no major improvement in 48 hours on IV meds, surgery to clean out the mastoid bone, mastoidectomy, is usually needed. Any drained fluid gets cultured. Empirical 5E antibiotics depend on the history. Vancomycin is often used initially if resistant bacteria are a concern, sometimes with other broad-spectrum drugs like cefepime or drugs covering Pseudomonas if risk factors are present. Then you tailor based on cultures.
And it's a long course, 7 to 10 days of 5E, followed by a full 4 weeks of oral antibiotics. Much more intensive than for simple AOM.
Okay, let's pivot to sinus symptoms. Inflammation of the sinuses, often called rhinosinusitis, because the nose is almost always involved too.
Duration matters here. Acute is less than 4 weeks, subacute is 4-12 weeks, chronic is 12 weeks or more.
And again, the list of other things that can cause sinus-like symptoms is long. The common cold, allergies, non-allergic rhinitis, rebound from decongestant sprays, side effects from meds like aspirin or beta blockers, autoimmune diseases, even a CSF leak sometimes.
Pain over the sinuses could also be headaches, facial pain syndromes, TMJ, dental issues. Even reflux can cause referred symptoms.
And red flags for more serious causes include uncontrolled diabetes or immunosuppression, think invasive fungal infection at emergency, or a foreign object in a child's nose.
Let's focus on acute sinusitis first. The material repeats a familiar theme. The majority of cases are caused by viruses.
Yep, and this is another huge area for unnecessary antibiotic prescribing. The source says less than 2% of acute sinusitis is actually bacterial, but antibiotics get prescribed in over 70% of visits for it.
70% for something that's usually viral. That's even higher than for colds or ear infections. The material actually says that based on current guidelines for when to use antibiotics, probably only around 20%, maybe up to 50% max, of adults actually meet the criteria.
It really highlights the gap.
Yeah.
So what symptoms bring people in for suspected acute sinusitis?
The main ones are thick, colored nasal discharge, feeling congested or full in the face, and facial pain or pressure. Others can include fever, losing your sense of smell, ear issues, postnasal drip, bad breath, upper tooth pain, cough, fatigue.
Risk factors include being middle-aged, smoking, asthma, allergies, air travel. On exam, looking in the nose might show thick mucus. There might be tenderness over the sinuses. Really severe cases might have facial swelling. And that old trick of shining a light through the sinuses, the material says it's not accurate.
Complications are rare but serious. Infection spreading to the eye socket, bone infection, meningitis, brain abscesses, blood clots in brain veins.
And the red flags for those complications: confusion, one-sided weakness, bulging eye, trouble moving the eyes, sudden vision changes. Get help immediately.
Recurrent acute sinusitis is defined as 4 or more episodes a year, with symptoms clearing up completely in between.
The material also mentions invasive fungal sinusitis, again, that emergency in immunocompromised people, rapidly progressing with severe pain, fever, spreading to eyes and nerves. Needs biopsy and imaging urgently. And nosocomial sinusitis in critically ill, hospitalized patients, often intubated.
Okay, treatment for acute sinusitis. The recommendation is that everyone starts with symptom relief, right? Whether they end up needing antibiotics or not.
Exactly. Get the symptoms under control first. That means decongestants, nasal sprays like oxymetazoline for max 5 days or oral pseudoephedrine, pain fever relief, acetaminophen, NSAIDs, saline nasal sprays or washes, higher volume might be better, and steroid nasal sprays to reduce inflammation, especially if allergies are playing a role.
And patient counseling is stressed as vital. Explain it's likely viral, focus on symptom relief, and tell them when to come back.
Those red flags for reconsultation include fever coming back high, over 102 degrees alpha, symptoms getting worse after starting to improve, facial pain becoming rapidly worse or constant, or any other really concerning symptoms.
And then, the material gives strict criteria for when antibiotics are actually appropriate. Only if symptoms are persistent, severe, or worsening after trying symptomatic treatment for a few days.
Persistent means lasting 10 days or more without getting better. Severe means high fever, over 102 degrees F, plus purulent discharge or facial pain for at least 3-4 days straight. Worsening means a typical cold is getting better around day 5-6, but then suddenly new fever, headache, or more discharge appears.
Those are really specific thresholds designed to catch the few truly bacterial cases. And like you said, probably only 20–50% of people meet these.
Right, and if they meet those criteria, the recommended antibiotic is amoxicillin clavulinate, 875 125 milligrams, twice daily for 7 days. Amoxicillin alone is an alternative.
Mild penicillin allergy.
Cefuroxime, severe allergy. Doxycycline. And it specifically warns against macrolides like azithromycin due to resistance. If antibiotics are given, you should see improvement in 3 to 5 days. If not, you might need to step up the antibiotic. Higher dose amoxiclav or levofloxacin, but watch for fluoroquinolone risks. Consider referral to ENT or get imaging. Non-contrast CT is best.
For recurrent cases, maybe nasal cultures during flares, imaging between flares, allergy, or immune workup. Invasive fungal needs IV antifungals and surgery. Nosocomial needs broad 5E antibiotics based on cultures.
Okay, let's shift to chronic sinusitis symptoms lasting 12 weeks or more.
The material describes this as primarily an inflammatory disease, though infection can play a role. It's complex.
Yeah, associated factors include infections. Repeated viral ones might trigger it. Chronic bacterial colonization happens. Allergies, structural issues like a deviated septum or polyps, and immune problems.
Allergens and irritants are big drivers, too. Dust mites, mold, smoke, pollution.
Functional issues like poor mucus clearance, like in CF, or immunodeficiency can predispose you, and it often travels with allergic rhinitis and asthma. Symptoms are chronic congestion, facial pressure, discharge drip, loss of smell, also fatigue, ear pressure, hoarseness, cough.
But you need to confirm it with an exam, looking inside, maybe endoscopy or imaging, because the material says up to 40% with chronic symptoms might not have actual mucosal changes.
There are different types described based on characteristics.
First, chronic sinusitis without polyps. More common in women, starts earlier in life, often presents with facial pain, linked to a Th1 immune response, often with bacterial involvement.
Second, chronic sinusitis with polyps.
Yeah.
More common in men, starts later, often presents with loss of smell, linked to asthma and aspirin sensitivity, linked to a Th2 eosinophilic inflammation.
Third, allergic fungal sinusitis. Also has polyps, usually younger adults in humid areas, often with other allergies. Strong eggy eosinophil response to fungi. Classic thick greenish-brown mucus, often resistant to medical treatment alone.
Evaluation involves looking for polyps, pale translucent growths. CT scan is the imaging standard. Unilateral symptoms are polyps, especially with bleeding. Think about tumors.
Treatment is multifaceted and often long-term. Avoid triggers. Saline washes help symptoms.
Intranasal steroids are the mainstays, especially with polyps. Sprays like mometasone, fluticasone, or higher-dose budesonide rinses can shrink polyps. Oral steroids for 2-3 weeks sometimes help if sprays aren't enough, again, mainly with polyps.
Antihistamines if allergies are involved. Montelukast might help. Antibiotics. Frequently prescribed for long courses, but the material says there's little evidence they work broadly for this inflammatory condition, except there's modest evidence for a long course, 3 months of macrolides for chronic sinusitis without polyps.
Antifungals, not shown to help medically for any type. Decongestants, used sparingly if at all.
Surgery. Endoscopic sinus surgery is often needed if medical therapy fails, especially with polyps. It improves quality of life by opening things up. Allergic fungal type often needs surgery plus steroids around the time of the operation. In kids, sometimes removing adenoids helps.
And the future might involve tailoring biological treatments based on the specific type of inflammation.
Okay, let's move down to sore throat and neck pain. Another super common symptom. The material distinguishes sore throat as broader than pharyngitis, which is just inflammation of the pharynx itself.
Good distinction. Other things causing sore throat besides pharyngitis: abscesses in the neck, thyroid inflammation, reflux, tumors, even just postnasal drip irritating the throat.
Focusing on acute pharyngitis symptoms developing over days, most common cause, viruses again.
Yep. The next most common, and the one we really need to identify, is group A strep, GAS, the strep throat bacteria.
Other possibilities include different bacteria like gonorrhea, viruses like EBV, mono, or acute HIV.
On exam, just redness, erythema, is common with viruses. If there's exudate, white yellow stuff, need to tell it apart from thrush, cottage cheese scrapes off, or leukoplakia, white patches, doesn't scrape off, potentially precancerous.
The history and exam can give clues, material references a table. Like a scarlet fever rash points to GAS. Cough or ear infection might suggest H-flu. Sexual history matters for gonorrhea or HIV. Travel history and a membrane. Diphtheria. Persistent sore throat plus lung symptoms. Mycoplasma. Marked swollen glands, especially back of neck. Big spleen, spots on palate, swollen uvula. Think mono. Let's zero in on strep throat. GAS of pharyngitis. The material is clear. GAS is the only common cause of sore throat that needs antibiotics.
So the main goal when seeing an adult with a sore throat is figuring out the likelihood it's strep.
Why treat it? In adults, antibiotics might shorten symptoms a bit, reduce spreading it, and maybe lower the risk of a local abscess near the tonsil.
But those scary complications like rheumatic fever, super rare in developed countries now, and antibiotics don't prevent the kidney complication, post-strep glomerulonephritis.
So the main benefit in adults is symptom relief, and maybe preventing an abscess, not rheumatic fever usually. And most sore throats aren't strep, they're viral. Yet doctors prescribe antibiotics for the majority of adults with sore throats.
Which is exactly why clinical scoring systems like the Center criteria are recommended. They help predict the chance of strep and avoid unnecessary tests and drugs. The material suggests most adults probably don't even need a strep test based on these criteria.
How common is strep throat? About 10% of adult sore throats, much higher in kids 5-15, maybe 35%, more in winter spring. Higher risk if you work with kids, have kids, or were exposed. Military institutional settings might have higher risk too.
Evaluating for strep often uses the Center criteria, referenced in a table. Simple point system, 1 point each for history of fever, no cough, tender swollen glands in the front of the neck, and tonsil swelling or exudate.
Easy to calculate, and it helps stratify the risk. Assuming a baseline 10% chance of strep, 0 points equal 2% chance, 1 point 3%, 2 points 8%, 3 points 19%, 4 points 41% chance.
So based on a hypothetical threshold, say 5%, if an adult has 0 or 1 point, which is 40–60% of adults with sore throats, the chance is so low, don't test, don't treat with antibiotics, just symptom relief.
Makes sense.
2 or 3 points. Intermediate risk, do a rapid strep test, treat based on the result.
4 points. Highest risk, 41%. Reasonable to either do the rapid test or just treat empirically with antibiotics, though some guidelines might still require testing.
In kids, center is less accurate. So the material says strep should be confirmed with testing in kids before antibiotics. Test kids who have sore throat signs without obvious viral signs, runny nose, cough, etc.
Some guidelines outside the U.S. don't even recommend routine testing or antibiotics for strep, arguing complications are rare and it usually gets better anyway.
But you'd have a lower threshold for testing treating if someone has a history of rheumatic fever, known recent exposure, there's an outbreak, or they're diabetic or immunocompromised.
Rapid strep tests, about 80% sensitive, 95% specific. Quick results are the big plus.
But technique matters. You got to swab the tonsils pharynx properly, hitting any pus or the sensitivity drops way down.
Throat cultures. More sensitive, 85–90%, but take 1–2 days. Delay symptom relief. And they can be positive in carriers, not just active infections.
So routine cultures aren't recommended for adults. The delay usually outweighs the small sensitivity gain over rapid tests. And just randomly testing everyone with a sore throat is discouraged. A positive test in someone with a low center score is likely a false positive or just indicates carriage.
Complications of strep are rare now, but listed. Rheumatic fever, kidney issues, scarlet fever, sinusitis, peritoncellular abscess, invasive infections.
Treatment for strep, when needed, references a table. Always symptom relief first for any sore throat. Pain meds, acetaminophen S-aids.
Saline gargles, humidifier, soft foods. Tea honey can help too.
Antibiotic of choice. Penicillin, narrow spectrum, cheap, well-tolerated, and crucially no GAS resistance. Dosing. 500 milligrams 4 times daily, or 1,000 milligrams twice daily for 10 days.
Amoxicillin is an alternative, often better for kids, tastes better. Dosing. 500 milligrams twice daily, or 1,000 milligrams once daily for 10 days.
Mild penicillin allergy, cephalexin or cefadroxil, severe allergy, erythromycin or clarithromycin 5 days, or clindamycin 10 days.
And the duration is key. You need the full 7–10 days, unlike some infections, to really knock out the bacteria.
What about steroids like dexamethasone for sore throat? The material says they're poorly studied and not recommended. Might slightly decrease pain in 24 hours, but don't help with missed work, school, or relapses. And even short steroid courses have risks. Sepsis, bleeding, heart failure, clots, fractures.
Sore throat should get better in 3 to 5 days. Red flags to seek more care. Shaking, chills, neck swelling, not just glands. Trouble swallowing, drooling, or symptoms persisting 5 days without improvement.
Other bacteria can cause pharyngitis, non-group A strep, mycoplasma, etc. But antibiotics aren't proven to help for those typically. Only treat if cultures grow group C or G strep and the core throat is persistent.
Acute infectious mononucleosis, mono, from EBV, causes 1–6% of young adult sore throats. Rare over 40. Classic triad isn't always present. Look for malaise, fever, sore throat, marked swollen glands, ISI posterior neck, maybe big spleen, exudate, spots on palate, gelatinous uvula. Blood tests show high atypical lymphocytes. Monospot test takes time to become positive.
Lemierre syndrome. Rare, serious clot infection in the jugular vein, often after pharyngitis, caused by fusobacterium usually. Spreads infection elsewhere. Lungs common. Suspect in teen young adult with non-resolving non-strep sore throat, especially with chills, neck pain, swelling. Mostly males.
Gonococcal pharyngitis from N-gonorrhea. Maybe 1% of sore throats in primary care, often no symptoms, can cause mild to severe protracted pharyngitis. Suspect in MSM, women with exposure or persistent sore throat not responding to strep treatment.
Diphtheria, endemic elsewhere. Mild pharyngitis under a characteristic gray membrane.
Acute HIV infection. Consider with sore throat plus headache, fever, aches, swollen glands, rash. About half with acute HIV have sore throat, but overall prevalence among those with viral symptoms is low, 1% in U.S. Okay, let's talk head and neck abscesses. Serious infections, collections of pus deep in the neck.
Risk factors include diabetes, weak immune system, older age, also IV drug use, bad dental hygiene, past tonsillectomy, congenital cysts depending on the type.
Need to recognize these quickly because they can block the airway.
And they can spread along tissue planes down into the chest, mediastinitis, etc. Involve major blood vessels, nerves, skull base, brain lining. Can lead to aspiration pneumonia, necrotizing fasciitis, Lemierre's, toxic shock.
Submandibular abscesses under jaw, usually from infected teeth. Can cause Ludwig angina, swelling, pushes tongue back, emergency.
Peridocillar abscesses, behind tonsil, often follow bacterial pharyngitis, more common in males. Fever, severe pain, trouble swallowing, drooling, can't open mouth well, trismus, that muffled hot potato voice. Yeah. On exam, one side of the palate bulges, pushes uvula away. Mix of bacteria usually involves strep, anaerobes, staph.
Retropharyngeal abscesses behind pharynx, often in kids after a URI. Sore throat, trouble swallowing, deep neck pain, stiffness, trismus, drooling. Wall might look pushed forward, but maybe not obvious on exam. Severe cases cause breathing difficulty, stridor.
Evaluation usually needs imaging CT scan unless it's a super obvious peridocillar abscess.
Treatment priorities. Secure the airway, drain the abscess surgically, give IV antibiotics.
Airway management can be tricky. Might need fiber optic intubation or tracheotomy. Peridocillar abscess, often drained with needle or incision, maybe tonsillectomy later. Others need formal incision drainage. 4V antibiotics cover strep, anaerobes, maybe staph, Amsulbactam, Clinda plus ceftriaxone, meropenem common. Interestingly, penicillin might work if drainage is good. Let's touch on epiglottitis, also called supraglottitis. Critical to consider this in adults with severe sore throat.
Especially if they also have trouble swallowing, painful swallowing, hoarseness, stridor, or rapid breathing.
Right. The epiglottis gets inflamed, swells up, and can block the airway. Patients might lean forward, extend their neck, drool because they can't swallow.
Can cause that hot potato voice too. And the warning. Examining the throat can trigger laryngospasm. Do it only carefully in a controlled setting.
This is potentially life-threatening due to airway obstruction. Patients must be observed in hospital. Examine the OR is often considered. Lateral neck x-ray might show the swollen thumb sign, but don't delay airway management for an x-ray if suspicion is high.
Used to be mostly high bacteria in kids, but the vaccine changed that dramatically. Incidence in adults might actually be increasing. Other bacteria can cause it in adults. Strep pneumo, strep pyogenes, Staph aureus.
Treatment in adults, if stable, might just be observation and supportive care, but intubation or tracheostomy might be needed urgently. Other treatments, humidity, steroids, IV antibiotics, maybe nebulized epinephrine.
And finally, laryngitis, inflammation of the voice box.
Most common cause, viral URIs. Again, in kids, parainfluenza can cause croup, which includes laryngitis plus that barking cough.
Bacterial or fungal laryngitis is rare. Bacterial might follow a virus after about a week. Strep pneumo, H. flu, Moraxella. Fungal is rarer, maybe in immunocompromised or after antibiotics.
Lots of non-infectious causes too. Vocal strain, yelling, singing, inhaling irritants, allergies, reflux, LPR, asthma, pollution.
Immunocompromised people can get herpes, HIV, Coxsackie laryngitis. Smokers have higher risk of cancer presenting as hoarseness.
Main symptom is the voice change. Raspy, hoarse, breathy, maybe completely gone. Maybe dry cough, throat pain, feeling need to clear throat. Diagnosis is usually based on history. Exam checks head, neck, lungs. If needed, looking at the vocal cords, mirror, or scope shows redness swelling.
Treatment is mainly supportive. It's self-limited, usually 3-7 days, maybe up to 14.
Key thing, vocal rest. Minimize talking, no whispering, no yelling. Humidity, hydration help. If reflux is suspected, manage that. And importantly, randomized trials show antibiotics are not effective for laryngitis. They don't speed up voice recovery.
Red flags needing emergency check. Shortness of breath, stridor, trouble swallowing, drooling, posture suggesting epiglottitis. Consider referral for voice professionals, smokers, or if symptoms last 3 weeks, need to rule out malignancy.
Wow. Yeah, we really have gone deep into Chapter 35 there, covering that whole landscape from the simple cold to some really complex infections and inflammations.
We really have. We've unpacked a lot of the nuances,
Yeah.
how often things are just viral and will get better on their own, the huge importance, and frankly, the challenge of using antibiotics wisely. There's specific signs and criteria that help sort things out, and the actual evidence, or sometimes lack of it, for different treatments.
Exploring the source material like this, at this level, it really shows how complex even common stuff can be, and how vital it is to stick to evidence-based approaches, not just, habits or assumptions. Hopefully this deep dive leaves you, the listener, feeling way more informed, more confident about understanding these very common health issues.
Yeah, definitely. We saw time and again how often these conditions just need time and how many treatments people reach for are either ineffective or carry risks that just aren't worth it for a simple viral thing. So given all that, here's something to think about.
Yeah.
How can we shift our perspective, both personally when we get sick and sort of collectively in how healthcare works? How can we really embrace informed patients? Focus on symptom relief for these viral things rather than always feeling the need for that quick fix, that intervention that might not even work or might actually cause harm.
That's a great question. What does really understanding this material, mastering these concepts mean for how you react the next time you feel that tickle in your throat or that familiar stuffy nose starting up?
Definitely something to mull over.